Welcome everybody to the first installment of the ADHD Parent Support Group webinars that we're going to be doing for all of our members in the private group. Thank you so much for everyone who was able to make it. Eventually, these may turn into opportunities for people who are really wanting to reach out. We've actually got a really great one coming up next month with Danielle Ralston. She actually posted the things to do to get your kid out of the house and to do things with them. Big post it's in our pinned thing in the group. She's actually going to be next month's guest. So this month we are joined by Dr. Carolyn Lyntzsch-Parcells. Dr. Carolyn Parcells is a board certified pediatrician. She specializes in ADHD and honestly has her hands in a lot of pies. So Dr. Carolyn Lyntzsch-Parcells, please introduce yourself to the people.
Sure. So as Shane said, I'm a board certified pediatrician. I do practice what's called adolescent medicine though. So I actually take care of kids ranging in age from about 10 to 25. But for the ADHD kiddos, I do see them as young as 6 because I'd rather get them earlier as opposed to later for sure. And I own a clinic here in Fort Worth, Texas called Our Place Adolescent and Young Adult Health, where we have medical providers. We also have mental health providers and dietitians. I personally do a lot of ADHD work, but we also take care of kiddos who are dealing with other challenges, other neurodiversities, eating disorders, mental and behavioral health, reproductive health, the whole gamut. So, but again, my heart and soul is in the neurodiverse world, and in particular the ADHD kids, because in case you haven't noticed yet, I am a member of the tribe and a proud member of the tribe, if I may say so myself. I am also a mom. So I have that perspective too. So I have the perspective of being a medical provider, but also a business owner, a woman with ADHD, a mom. So I think that gives me at least a slightly unique perspective and what I like to share with folks. And as Shane mentioned too, so I am on the planning committee. I also, as of the summer, I'm on the national board of directors for CHAD, and that's been really cool.
All right, so let's get into it. So ADHD parent support, one of the biggest things that we've seen in the group, and it often comes up, is a lot of people come in and they are dealing with children who are 3 and 4. Like, at what age do parents really need to be looking at their children and going, is that ADHD? Is that just 4-year-old bouncing off the wall because I gave them 14 cups of sugar earlier with the Mountain Dew? Like,
Yeah, don't
what
do
age
that.
yeah, what age do parents really need to be looking at when it comes to ADHD symptoms, and when should they look
Yeah.
at getting diagnosis?
That's a really great question. Of course, like everything else, it really depends on the kid and it depends on the family, right? Most, I would say in general, 6 years and up is kind of when most kids are going to get diagnosed. 6 is kind of the earliest that a lot of people, I'm not going to say it's the earliest absolute. So this is a caveat. I'm going to swing back around. 6 is kind of the classic earliest age for when most kids are going to get diagnosed, for when most providers are going to be comfortable diagnosing. And the reason for that is because, kind of to your point, like below 6 years of age, it's kind of hard to say, is it ADHD or is it normal development or typical development? I don't like the word normal, that's boring. Typical development within the range of what we would consider norm versus ADHD. It's particularly difficult with boys because the range of normal developmental behavior for boys is actually wider than it is for girls. And that's, of course, girls and boys assigned female and male at birth. But with that said, that doesn't mean that kids can't be diagnosed younger. Certainly kids can be diagnosed at 5 or 4 or 3, but the younger you get, the less likely it is that a definitive diagnosis will be made because, again, development, right? But also because we don't want to prematurely diagnose kids either. We don't want to wait too late, but we also don't want to prematurely diagnose. And I think severity comes into play there, level of dysfunction, like how is it affecting the child's life? How is it affecting the family's life comes into play there. And then also the other part of it is if some families are just going to notice it quicker because it runs in the family and they're well versed in it and they know. I mean, we joke that if you open up the DSM-5 criteria for ADHD, it's just my family tree. Like, So we're maybe even a little too attuned to it, where we have to be careful that we don't just like project ADHD on like every single member of the family, because it's not every single member of the family. And so that can be kind of a catch-22 in and of itself, right? As if you're well versed in it and you know what you're looking for and you live with it yourself. On the one hand, you're more likely to see it in your child earlier. And on the other hand, you got to be careful that you don't project it too, right? So that can be a little bit of a double-edged sword as well. When it comes to when's the right time to diagnose, it really depends on the child and the family and what are the challenges or struggles that you're seeing. And are these things that we need help and need to intervene on, not just with medicine, but with other interventions. I'm a big fan of early intervention and early diagnosis if it's appropriate, because we know the earlier we can intervene with kids of all kinds of conditions or neurodiversities, the better we can support them and start building those positive coping strategies early.
Yeah. I'm a big fan of it. Like going into it with my 5-year-old twins, we had first off, they were preemie, 27 weeks.
Which
So
was
like we are, yeah. So we knew neurodevelopmental was going to be on the table. Also me. My wife being a special needs teacher.
genetics.
So, right. My wife being a special needs teacher, she's definitely going to be paying a lot of attention to that. And there's no objectivity as a parent. So,
No.
but it was really cool because here in North Carolina, because they were on preemie watch list, we got access to a lot of resources.
Yes.
And I think that was the kind of key that really helped me was I actually had people telling me, okay, we're going to actually be looking for these traits, right?
Yes.
We're at this timeline. This is the adjusted timeline.
Yes.
And I realized that a lot of people don't know and they don't have access to those resources.
Right.
What are the next steps if they suspect ADHD and it's getting problematic and things of that nature?
Sure.
Or even if it's not problematic, but it's just like maybe
But you're just noticing it. Yeah.
Right.
And you're like, what do we want to do? And I think too, one of the points I want to make, because you kind of touched on this or alluded to it a little bit, is I think the other reason to diagnose children on the earlier side is for the sake of the parents. We don't like to say that. We don't like to say that like we should be doing anything for the sake of the parents as opposed to the sake of the child. But the fact of the matter is children do not live in a vacuum, nor do parents, right? And our ability to optimally understand our child and understand our own responses to our child and understand what methods and modalities and strategies and structures work for them and us, the sooner we do that, the better. And the less parents can feel shame about those things, the better off they're going to be, which means the better off their kids are going to be. So I just had to jump on my soapbox about that for just a hot second.
That's a hugely common theme in the group is parents coming in and talking about, what did I do wrong? What am I doing wrong? What am I like? You didn't do anything wrong. You're just in a situation where you don't know enough and you're just overwhelmed.
Yeah. And your child does not respond to parenting strategies the same way neurotypical children respond. And unfortunately, society likes to make you feel like that's your fault.
Right. We think about books like What to Expect When You're Expecting, right? Super generalized towards neurotypical, very little information on neurodivergence.
Yeah. The other thing that I had to learn the hard way when I became a parent, I started private practice before I had children. And I thought that I was going to be fabulous at taking care of ADHD because I had ADHD. And of course, all of those things are true, right? But I did not get it all the way as a parent until I became one. And that's not to say that obviously physicians who don't have children can't be absolutely excellent physicians and pediatricians and guide parents, but my perspective changed a lot. And there are families I would love to find from 15 plus years ago and be like, hey, sorry, my bad. I really genuinely didn't completely understand the struggle, the level of shame, the level of guilt, the societal pressures, like all of those things, obviously, until I was in it myself. It didn't really necessarily change the kind of medicine I practiced, but it changed the way I approached it. And it changed the way I approached parents and the level of support that I provided parents. But coming back around real quick to what you were saying about the kiddos, your twins, you were talking about little ones. Oh, where to start?
Yeah, start.
We're definitely having an ADHD convo here. So where to start? So first and foremost, coming back to that, your pediatrician. or family practice doctor, whoever your primary care provider is for your kiddos. That is the first place to start. And sometimes some of those people, like myself, are actually quite well versed in ADHD or neurodiversity. It might be their passion. It might be something that they know about personally. And so they can be a very good place to start. Now, a lot of general primary care providers these days are not necessarily comfortable with diagnosing. Sometimes they're comfortable with treating once it's been diagnosed. Some folks are comfortable with diagnosing and treating. If they're not comfortable with diagnosing and treating, then they're going to be the ones to know, or at least they should be the ones to know in who in your area specializes. So for pediatrics, from a medical standpoint, that's going to be either a general pediatrician, family practice doc, a developmental pediatrician, a pediatric neurologist, or a pediatric and child psychiatrist. Those are the folks that typically take care of ADHD. Now, for diagnosis, it can be any of those people. Sometimes it's not required for diagnosis. I want to be clear on that. But sometimes, especially if they're on the younger side, and especially if there's concerns for other things besides ADHD, so learning disability, autism spectrum disorders, other conditions, then they might require or recommend full what we call neuropsych testing or psychoeducational testing. And that's done by either a Ph.D. psychologist who's trained in those assessments or a master's level diagnostician who's trained in those assessments. Now, the challenge with those can be anywhere from half a day to a full day to multiple days. They usually start with the diagnostician speaking with the parents first. Then they do a whole lot of forms from the parents and the teachers. Then they do several hours. It depends on the situation and the age of the child, of actual testing of the child. And then they take a crud ton of time, rightfully so, to gather all that data and put it in a little novel that goes through everything they witnessed, everything they saw, the whole history, all of the scores, and they kind of put it together into here's your diagnosis, assessment, and recommendations. Interestingly, one of the things a lot of people don't totally understand, ADHD is a neurodevelopmental disorder, not a mental health disorder. It is hardware, not software. Same with ASD. So that's actually, technically speaking, has to be diagnosed by a physician or medical provider of some sort. Now, what a lot of them do, though, is take that assessment. The assessment says diagnosis meets criteria for ADHD or ASD or learning disability or whatever it is. You bring it back to the physician. The physician goes, cool, let's do that. So what is interesting, though, and one of the things that I kind of get up on a high horse about is when it's ADHD, when it's just strictly ADHD, when that's the main thing we're looking at and we're not worried about learning disability or ASD, that testing should not be required. Unfortunately, that testing is often required, if not by physicians or medical providers. As they get older, it can often be required for accommodations, especially in standardized testing and or college. The reason I have a major issue with this is because that testing is often not covered by insurance. It is not cheap. It depends on where you live and it depends on the extent of the testing, but we're often looking at anywhere from $1,500 to $5,000. And that is cost prohibitive to a lot of people and certainly to our most vulnerable. Federal law is you can get that testing for free through the schools, but obviously the school district varies in quality, availability, etc. And actually what the law says is not that the school is required to do that testing if you request it. If you request assessment, what the school is required to do is an informal assessment that determines whether or not they think formal assessment is necessary. Okay. And so the issue with all of that is then our most vulnerable are at the most disadvantaged to get that testing, which means they're less likely to be able to get things like accommodations on standardized tests for college entrance, standard accommodations for middle school, high school, college. And that really chaps my hide. I'll just be totally honest with you. And I appreciate that people want to make sure people aren't skirting the system and things like that. But making it harder for the people who need it to get the help they need is not the way to do that.
Yeah, and we're seeing that pan out when we look at the prison populations. 85% of them have some sort of neurodivergence or mental health.
Exactly.
And
Exactly.
it's really important to understand that, like, the whole reason why we're doing this thing as the ADHD parent support group is to let's start the conversation as early as we can. Let's educate and let's really get the resources and the understanding out there so that they can start at least asking those questions and get in
Exactly.
the direction that they need to go.
Yep.
Because it's not always just as easy as Googling ADHD doctors near me,
No.
especially if you're in one of those underserved communities. Who do you talk to at the school? By the way, I've got a whole fucking guide on that in the parents group in our
Yep.
files, is a
Good.
whole breakdown on the IEP and
IEP and
504.
504. Yeah.
So one of the things that I've seen really becoming a lot more obvious on a lot more website, Chad, ADA, ACO, and a large number of them are really starting to put out that parent training
Yes.
is one of the first steps when
Yes.
it comes to ADHD management with
Mm-hmm.
children. Can you talk about that and what that is and why people go to therapists and coaches for that kind of stuff?
Sure. So it's actually very specific. It's parent behavioral management training, if I remember correctly, if I'm saying that right. And it's a very particular form of training for parents. And it is recommended as first-line treatment for ADHD by the American Academy of Pediatrics. It is first line for kids ages 4 to 6. That's a one age group that medication is not first line for. And then it's still considered first line for elementary school age kids, in addition to medication and classroom accommodations. The challenge is, this is one of my frustrations. So I appreciate that the AAP said, hey, look, there's evidence to support this can be really helpful. But what there wasn't a whole lot of good support for is providers understanding what that really is, but also where do you get it? Because if you don't understand that parent behavioral management training is its own specific entity, you might just send somebody to a counselor. And not all counselors do this. And CBT is not effective for ADHD symptoms. And that's nothing against CBT. Love CBT. Think everybody should be in therapy. Living with ADHD in our world can lead to things for which CBT can be very helpful for, like depression and anxiety. But for the ADHD itself, that is not effective treatment. Okay. And so it's a very particular form of treatment that helps parents understand and have tools for their toolbox in how to manage the behaviors of ADHD and ADHD children. And those programs and the people who do that are not, I mean, you think it's hard to find a medical provider. Like, I feel like it's even harder to find those programs. The good news is, not happy that the pandemic happened, but one of the few kind of hashtag silver linings of all of that was how many of programs became virtual and have continued to be available virtual. Of course, you got to be careful that they're not scamming, that they are what they say they are, right? But like, for example, Impact Parents, Elaine and Diane's program, love that program. I love they call it Sanity School. Like, yep, that's appropriate. That's appropriate. And they have that for teachers and parents. There's a lot of other online resources. But yeah, it's hard because it's an actual definitive term, not just random training for parents.
Also, there's Brennan Mahan, ADHD Essentials, does a
Yes.
lot of parent coaching. Definitely got to give him a shout out. He's one of our friends.
He's fabulous.
Yeah.
I don't think he does specifically the parent behavioral management training.
No.
He does parent coaching.
Yeah.
And his parent coaching is fabulous.
Yep. So kind of looking out there, therapists for the behavioral training, check out ADHD parenting coaches like Brennan Mahan. I guess one of the next questions that we get a lot about is the emotional outbursts. Can you go into about emotional regulation?
Yes. Okay. So emotional dysregulation, also known as outbursts, meltdowns, whatever you want to call it. There is a large number of us who really, really want to see emotional dysregulation be considered one of the core symptoms of ADHD and be part of the diagnostic criteria. Right now, it is not. It's considered an associated symptom, but I think for those of us who live in this world, we know that's bull honkadonk. And while emotional dysregulation does not affect all people with ADHD, it does affect a lot of us. And for some of us, it is the number one symptom that causes us the most difficulty, whether it's school, socially, work, etc.
Yeah, I'm right there with you.
Dude, if I do not want to take away my ADHD, but if I could wave my magic wand and make one of those symptoms go away, that would definitely be one of them. And you see, actually, what I would say is not take it away. I would wish for the ability to manage it all the time. Even when I'm tired and hungry and stressed.
Yeah.
Yes.
I thought about that a long time ago because it came up in the men's group. But like, if you could get rid of your ADHD, would you? And I'm like, one aspect,
Depends on the day.
Yeah, and it's definitely emotional dysregulation. And I'd mentioned it. And somebody said, "Well, what about the good stuff?" And I said, "Oh,
So here's the challenge. So emotional dysregulation. So this is the way I describe it. Please do not take this as like evidence-based research. No, this is personal and clinical experience, although much of it. When we talk about emotional regulation, here's how I like to think about it. First of all, a lot of us, not all of us, but a lot of us tend to be big feelers. We feel things more intensely than the average bear. So there's that piece of it. Okay. Then you add to that impulse control difficulties.
right."
And then,
Little ganglia.
right, you add into that. So I like to describe us as we're not dimmer switch people, we're flip switch people. So we're either on or we're off. And we're now understanding that ADHD, not just emotional regulation, but it's not an issue of attention and focus. It's an issue of self-regulation. So we are on or we are off our attention, hyperfocus or difficulty focusing. Motivation, we are locked on, it is on like Donkey Kong, or we can't get ourselves to move at all. Energy, we're greyhounds. We are either racing and faster than anybody else, or we can't get off the sofa, right? Emotions, we are either like just full on intense emotion, or we shut it all the way down, which, oh, by the way, that flip-flop is one of the things that's really hard for us, but it's super hard for the people around us because they never know what to expect, right? And sometimes we just shut it off. If it's like, you know what, I can't do this anymore. I can't do that. I'm just going to do nothing. And it really messes with the people around us, not to mention messes with ourselves.
Daughter has a trigger point. Like, we'll get into more on tips and tricks here in a little bit, but like when she's just absolutely done putting away toys, she face plants to the ground, butt up in the air, face plants to the ground, and just whispers, "I'm tired." And we're just going, "This is the most adorable thing ever. You've got 5 more toys to pick up."
We can push through. And what's interesting is one of the things I talk to parents about, and this kind of leads into some of the tips and tricks, is classic behavior management strategy is ABCs, right? Antecedent, what triggers it or causes the behavior,
Yep.
behavior itself, and the consequence. Here's the problem. Normal, typical behavior management strategies depend on there being a point where you can intervene between antecedent and behavior. And we don't have that because of impulse control or lack thereof. So it's like thing happens and whoosh, there's no in between. There's no splits. Well, we can get there. But for the most part, we oftentimes don't have or don't feel like we have that split second moment between the thing and the behavior to access strategies or to go, hey, how do I want to do this? My mother likes to call it ready, fire, aim.
Yeah, that's about right.
I've kind of evolved that a little bit to be fire, aim, ready. But point being, we fire before anything else. And that's why it's like, I think for a lot of us too, it's that moment, like, it's almost like slow-mo, right? As you get older, at least, it's like, and then it's too late. And you spend a lot of time either apologizing and feeling bad, or as a defense mechanism, you go the other way and you blame everybody else and start covering your tracks and digging your hole deeper.
Right.
And so that can be really, really difficult for folks with ADHD. It can be difficult for parents and friends and other people. Now, let's complicate things even further by remembering the fact that ADHD is largely genetic, which means that oftentimes as parents, we're struggling with emotional dysregulation as our children are struggling with emotional dysregulation. Our brains have not evolved nearly as much as we would like to think they have. And this is for all people, not just ADHD people. Our brains, when we get anxious or angry or scared or nervous, our brains react like we're getting chased by the saber-toothed tiger still, right? It's literally fight or flight or freeze. And that response is in the amygdala, which is in the central part of our brain. It's the less evolved part of our brain. That's the impulse kind of survival center. And the frontal lobe, so if this is your brain, this is my little hand brain. The front of your brain, amygdala is in here. Front part of your brain, prefrontal cortex, this is responsible for impulse control, executive functioning, logical thinking, logical decision making, right? Well, when we get particularly anxious or angry or scared or nervous, this takes over and this no longer can suppress it. Okay. Which actually makes sense if you are trying to, if it is a survival issue, because the last thing you want to do if the tiger's chasing you is sit there and contemplate your choices or you're going to lose an arm, right? So it makes sense that this takes over. The other thing we lose, though, and this is what a lot of people don't know, we lose our verbal centers. Like blood flow literally leaves the front part of our brain and our verbal centers, our higher level verbal centers, which means not only do we have trouble utilizing language, especially complex language, we also have a hard time taking in complex language. Now, again, in the context of running for your life, this makes sense because you don't want to be stopping and trying to have a conversation with the lion as to why he shan't be chasing you. Okay. But unfortunately, most of the times we're experiencing this in our modern world, those are the parts of the brain that we kind of need to function better. Now, that, like I said, that's for everybody. But for people with ADHD, we have less of this control to begin with, which means we live closer to this taking over. So if you put anything else into the mix, anxiety, being tired, being hungry, being stressed, it is not hard for us to go from this taking control to this taking control. The other thing I tell parents, because we end up in these situations where the kid starts to lose it and meltdown, and then we start to lose it and meltdown, because what do? We say, tell me what's wrong. And because I just told you they don't have their verbal centers intact, can they tell you what's wrong? No, they can't. And then that frustrates us. And oh, by the way, as parents, as mama bears and papa bears, are we programmed to flee? No.
No.
Are we
Fight.
programmed to freeze? No. We are programmed to maul and kill anything that threatens our babies, sometimes including our babies. So when we're in this state where they're in this heightened state, it puts us neurologically, biologically, understandably in a heightened state ourselves. And then we're struggling to manage our stuff. And they're having trouble managing their stuff. And nobody's verbal centers or frontal lobes are functioning properly.
Yeah, because the child is sitting there screaming because they're starving to death, and their brain apparently has hit the point where actually death is on the table. You should
Or is it
feel a
brain
certain
start?
and then of course the parents sitting there and say, "What do you want? What do you want?" The child cannot speak, and like they're not in a place where they can function, and like and they're not feeling heard. So now they're angry because I'm not being heard. It's just a huge mess.
It's a
Oh my
mess.
gosh.
It's a mess. And then it ends up with everybody feeling bad, everybody feeling guilty.
Yeah.
It's tough stuff. And by the way, all families face this stuff to
yeah.
a certain extent. It's just that those of us who have ADHD or other neurodiversities in our households definitely face it more.
Right. We see a lot of parents come into the group and they're just like, my child is Satan. And we're like, should we allow the venting in the group? I'm like, look, I feel like, yes, we should allow the venting in the group. It definitely needs to be a thing. But let's start talking about, all right, let's make sure we're building a culture of people who are reframing it, or, hey, you're really stressed out, mama. Have you taken some time to yourself?
Yes.
Do you need to talk? We're seeing that in the group. I'm really happy about that kind of stuff. So that being said, let's actually get into the tips and tricks. We even had that come up with a question. When we're talking about emotional regulation, because that's what's on the board right now, what are some ways for parents to really start to work on the behaviors, right? Because there is no, that, like you said, there's no gap there to put the thing in place. So how do we identify what's the goal here?
So there's two books in particular I want to recommend. The first one is The Explosive Child. That is one of the most important books I've ever read as a parent, as well as a provider. And it was a book that was incredibly important to other members of my family to understand these things as well, especially members of my family that are neurotypical. And one of the most important points of that book that will stay with me always is a child who can do well will do well. One of the most important things that book does, and it does give very particular, specific, actionable tips, but it also talks a lot about reframing the behavior. Because one of the problems we do get into, and it's so hard not to, and we all do this, is when we get into the mentality of like words that I want to see just never exist in people's vocabulary: manipulation, lazy, oppositional defiant disorder. I want to get rid of all of those terms and all of those words. Those words are not helpful. Whether they're descriptive or not, whether they're accurate or not, they're not helpful. Okay. They describe behavior in a very volitional and negative way. Whereas if you reframe the behavior and say, okay, this child is doing this thing in this way that is not the most productive way to do it because they do not have the skills or the development to do it a better way. So I always tell people the behavior for anything, the behavior is not the problem. It's the symptom. Okay. And in this context, it's the maladaptive behavior that a child or a person, adult even, right, has come up with to deal with something they don't have better tools to deal with. Okay. So that book has a lot of really good tips and tricks, but it also speaks a lot on reframing the behavior, which is so important as a parent, because if we can reframe the behavior, that helps us stay more positive towards the child and not lose our crap so that we can manage it more positively and better. The other thing I like about the book is that's also one of the first places where I really came face to face with collaborative problem solving. Core concept of collaborative problem solving is, and this can actually, believe it or not, you can do this with almost every age, at least if they're verbal. Okay. It just varies exactly how you do it based on their age. But you can also do this with spouses and friends and colleagues and work people and neighbors. But it's the concept of at least two people, sometimes more, but you both have needs and wants for a particular circumstance or situation. You come to the table, you discuss what those are, you discuss possible solutions, you agree on a possible solution to try, okay? And then you come back to the table and say, it's kind of scientific method for relationships, right? Hypothesis, thesis, experiment, conclusion, right? And if the conclusion is great, that worked, and that worked for everyone involved, and that met all the needed needs, then great, you continue doing that. If it doesn't, then it's not anybody's particular failure. It didn't work for us. It didn't work for this particular scenario and this particular context. So let's come back to the drawing board and come up with a different solution. This is great for a lot of reasons. First of all, it takes some of it off the parents, although it's still up to us to make the final decision. And I'm always clear with kids, and I'm clear with my kids on this, in the sense that we are still the parents. It is still our responsibility to make the ultimate decision on what we think is best and safest for you, because that's an appropriate boundary. It also takes some of the stress that should not be on them off of them.
Yeah.
But bringing them to the table, first of all, kids will come up with solutions that you will never think of that are fabulous and creative. And you're like, wow, that actually really makes a lot of sense. For another, if they have buy-in because they participated in the conversation, they will be more likely to actually follow through or buy into it. And you'll have a little less friction in implementing whatever the solution is. I think possibly the most important thing of that strategy is you're teaching them the skill of solving their own problems, which is ultimately what we want them to do as healthy, happy adults, right? Who are no longer living in our house.
Yeah.
Okay. For all of those reasons, and by the way, I am not saying that sometimes you don't just put your foot down and say, because I said so. Okay, there is a time and place for that too. We're just talking about a particular strategy. And again, it also doesn't mean that you as a parent have to relinquish all of your boundaries. So for example, if we're talking about bedtime, right? And the kid's like, well, but they keep pushing bedtime and pushing bedtime and pushing bedtime, right? Okay, no, your boundary is, as the parent, you have to get enough sleep. So you need to be in bed, lights out by, let's call it 8:30. We don't know the age of the child. Let's call it 8:30, right? And the child's like, but I want my drink of water and I want my story and I want my time and I want to play basketball. Okay, well then I'm not going to move the 8:30. But let's talk about how we accommodate that if it's accommodatable within the family's schedule, right? Leading up to bedtime. But if we're going to be in bed, lights out at 8:30, then let's backtrack and let's talk about how to do that from a schedule standpoint. So it's like that kind of thing where you as the parent are still laying down what needs to be the structure and what needs to be maintained, but still giving them some agency in it. And of course, again, how much agency you give them depends on the age. It depends on the issue and the topic at hand. The other thing I really like in that book is that it talks about how, and this comes back to what I was talking about as far as the like frontal lobe and amygdala. Let's make sure everybody has their best shot at firing in all cylinders and those neurons actually working well enough to have those conversations. So that means we don't have those conversations unless folks are calm. We don't have those conversations in the midst of the chaos. We make sure everybody's eaten. Nobody's hangry. Okay. Those kinds of things. It talks about how you got to meet the basics. Otherwise, we're not going to be functioning properly no matter what interventions we use. Another book I really like is Elaine's, The Essential Guide to Raising Complex Kids. And I like that one a lot too, because by the way, all of these are on audiobook because I hate reading. So I don't recommend anything that's not also on audiobook. Both of these are also very short and you can either read them cover to cover or you can go subjects or issue specific. And her book kind of teaches parents how to coach their own kids, which I think is really cool too. But one of the biggest things for me, and I try to remember to do, but we were talking about how we all get into that kind of what I like to call amygdala storm. And sometimes it is absolutely not just important, it's critical to say, to kind of time out, right? Like we've gone over the edge. This is not going to be productive. Everybody to their respective corners, rooms, quiet place, whatever. And that doesn't mean that we're avoiding the issue, right? It has to be followed by once everybody's kind of chilled out and let their blood flow go back to the proper places in their brain, we're going to come back to it and we're going to talk about it. Once a kid gets into that mode, for a lot of our neurodiverse kids, the more you try to talk to them, the more you try to reason with them, the more you try to touch them or even come near them, the more you're going to exacerbate it. And so making sure they're in a safe space where they can't hurt themselves, they can't hurt somebody else, and waiting until they have calmed themselves, right? Which can be 10 seconds. It can be 5 minutes. It can be half an hour. It can be an hour. Now, of course, I'm talking about, this is hard to do if you're out and about.
Right.
Sometimes this means going back to the car and sitting in the car. Obviously, it's easiest when you're at your home, or at least for some people, it's easiest when they're at their home. I also know families for whom it's really challenging because if they live in a multi-family dwelling, whether it's apartment or a duplex or whatever, that can be challenging too. But ideally, if you can, and you just wait. And this does a couple of things, especially as they get older. They don't want to wait. So when they can start to control it, they do. It teaches them how to self-soothe and self-regulate. And also it keeps you from ramping yourself up quite as much. There was a behavioralist I used to work with. I loved how she said this to me. She said, do not fall into the fallacy that they can't control it. There's a difference between can't and hard. It's okay to recognize this is extremely hard for them, and it's much harder for them than a neurotypical kid. There's nothing wrong with that. But if you think they can't, they will believe they can't. Right? And that's not a growth mindset. That's not going to help them learn. That's not going to empower them to take control over it. Right? Because we want to give these kids grace and mercy and understand that this is not something that's easy for them and they may not have all the skills, and we don't want to be blaming. But at the same time, we have to be careful that we don't do that to the point of taking away their power and their agency and their ability to believe that they do have the power to eventually get this under control for themselves. And that's
Yeah,
a very, very tricky line to walk.
it really is. I think with our kiddos, one of our biggest ones is the living room, right? Is cleaning the living room because that's their play area and they have things everywhere. We're just like, when we were originally working on it, it was a lot of us telling him to do things, right? And we fell into that trap. And we were like, okay, we would tell them, like, hey, clean the living room. And our kids would look at it. And of course, they're 5 years old, 4 years old at the time. And they're going, all of this?
Right.
And so my wife's special needs teacher. I'm ADHD person too. So I'm like, okay, what you were talking about earlier. All right, let's sit down. What is reasonable? And at first we started with time.
Yes.
Right? Like, let's spend 10 minutes cleaning up. But that still didn't make it small enough.
Yep.
They still had like time, also a meaningless in this household. Time is a thing, not really.
Is
And
it?
yeah, apparently. So we were like, all right, what would work? What can we do to help y'all clean up things? How many toys could you clean up? This is my wife. How many toys could you clean up before you got too tired?
Right.
That was her major. We get too tired, mommy and daddy. Okay, fine.
Yeah.
Whatever. That's the term you want to use. How many toys? 10? Cool. All right. So I'll set a timer for 3 minutes. You get to do whatever you want. When that timer goes off, go pick up 10 items.
Yep.
And then like they get through it and they realized 10 items was a little bit much. And so both of them come back to us and we think we should only pick up 5 items. I know this is my son because he's the math nerd.
Yeah.
Okay, but we'll do 2 minutes. And it was that back and
There you
forth.
go.
And so
There you go.
they're giving us,
Collaborative problem
right,
solving.
collaborative problem solving. And I just like, and I looked at Darcy, I was like, there's no way this works. And she's like, and so when we go clean,
Yep.
Liam's like, Alexa, set a timer for 2 minutes. Back on his phone.
Yep.
Okay. 2 minutes. Beep, beep. Time to clean, Harley. And he like runs and finds 5 of the smallest things ever. I'm like, that's fine.
I have 2 timers sitting right here, literally on my desk.
Yeah.
Okay. This is, so that brings us back to like kind of the antecedents, right? Like, what are the things that can kind of trigger stuff off, and how can you do things in a way that minimizes the risk of the meltdown? And what you just brought in is perfect. So we do well with urgency. We do well with gamifying things, right? Play is awesome. You make it a game or a competition and we are locked in, right? Also body doubling. I had a great talk with a family just the other week. Kid is like, she's like 11, 12, somewhere in there. Okay. And it was getting the room cleaned. Right. And understandably, mom wanted her to clean her room. Room's a mess. She wants her to do it on her own. She wants her to be able to do it on her own. All of that. Well, we really kind of dug into what the challenge was for her, which is all of the things you would expect from an ADHD kid. It was overwhelming. There was just too much, didn't know where to start, has trouble getting rid of stuff. The organizational structure is kind of overwhelming, all of the things. And then though they said, she's like, yeah, but my cousin came over the other night and we were able to do it together in like 2 hours. And I said, yeah, it's called body doubling. And she's like, what? And I was like, no, that's like an actual thing. It's easier for us to do stuff if we're doing it with somebody else. That person could literally just be sitting there talking to us. But it's still going to be easier for us to do stuff. And I started telling her how I use body doubling to like get my charts done or clean out my closet or whatever. And her mom's going, oh, so when she asks me to help her, I'm like, yeah, help her.
Yeah.
Like, but you can determine how you're helping her. But this is actually a really positive strategy, because one of the things, and again, I think this is for all humans, regardless of neurodiversity, is one of the most important things we can teach our children is not just how to do things on their own and be independent. It's how and when and who to ask for help.
That's huge. That's huge.
Right? Right. And there's a
And
difference between a kid saying, hey, can you help me clean my room? And then they sit on their butt on the bed and want you to do it all for them
yeah,
versus they recognize this is something that actually helps them to do the thing, right? And you balance that, right? And like for example, what you did with your kids, I love that because what you didn't do was say, you know what, that's okay. You can't pick up 10 toys, which sends the unintentional message of you can't, which is not something we want our children to hear from us, right? On the other hand, we want to have realistic expectations. So you're like, okay, but, or
yeah.
actually, I prefer yes and,
Yes,
right?
and
It's yes and, right? Yes, and we're going to set it for 2 minutes, right? Because one of the things I tell my own children, one of the things I have to tell myself, and one of the things that I tell my patients all the time, especially those who are really struggling, is you can do hard things. And I tell my kids, I'm not going to ask you to do something you can't do. So if I'm asking you to do it or I'm telling you to do it, by definition, it means you can. And I think that's one of the things that again, I think this is challenging for all parents. But again, when you have neurodiverse kids or 2E kids or just anything, kids who don't exactly fit in the box, right? Which is a lot of kids. It's so hard because you want to set reasonable expectations, right? For them and for yourself, but you also don't want to underestimate who they are or what they can do because kids look to you, especially when they're young, they look to us as the adults in their life for who they are, what they can accomplish, what their self-concept is, all of that. And so that's another one of the really significant balancing acts. And again, I call it a balancing act because I feel like every single day you're shifting, you're
yeah,
changing, you're trying to figure out what's right for this kid in this moment at this particular moment in time. And it's a hard
yeah.
one.
There's an important thing that you just touched on that I really want to expand on from my own personal experience. We have to understand ADHD and autism, these are neurodevelopmental conditions, right? From birth to 12, things are going to be different. Your child is going to be at different levels in different ways throughout it. This is normal across the board. There's no such thing as all children meeting the same. We just did that for education purposes. But children with ADHD and autism specifically are a little further behind in certain areas, such as social behaviors, executive behaviors, emotional dysregulation across the board. All of these are going to be very different for them. So you have to adjust your expectations.
Right.
And you really have to make sure that you're putting in these tips and tricks based on where your child is at, right? And that's why you need to be working with professionals to understand ADHD, right? You can see hyperactivity in children that are 8 years old that is reminiscent of that of a 4-year-old because it can be that length of time in there, 2 to 4 years.
Yeah.
And it's important to meet your children where they're at.
So I was going to say, just piggybacking on that is the concept of our 2E kids, right? Our twice exceptional kids is you can have a kiddo who the term we like to use is discordant development. So you can have a kid who's ADHD or autistic and their frontal lobe development and their social and emotional and executive functioning development as a result is 2 to 3 years or even 4 years behind same age, same gender peers. But their cognitive development is ahead of those peers. And then their physical development could be anywhere in that spectrum. And that can be incredibly difficult for them. It can be incredibly difficult for their teachers, for their parents, for their peers. It can be really, really tricky because they're not on one trajectory or the other with the development. And of course, then they hit adolescence and it's even more complicated and funsies.
Right. That was me when I was growing up because my dad's favorite term for me was the smartest dumb kid he ever knew. Right. And like I look back and I'm like, that was a really mean thing to
Like,
say to me,
true.
Dad, but take the compliment because I was hyperlexic. I learned to
Yeah.
read super early, and it was really important for me to know all the things to the point that my dad's solution to the problem was like for my 7th birthday was to give me the 1988 Encyclopedia Britannica. And then from age 8 to 12, I read it.
I remember that Encyclopedia Britannica. We had that Encyclopedia Britannica.
Like, I would go ask my dad and I would say, "Hey dad, what's this random thing, whatever it happened to be? Why did chickens have different colors, whatever?" And my dad was like, "Go look up the chickens in the encyclopedia, boy, and leave me alone." And my dad accidentally discovered my thing, right?
Yeah.
But at the same time, getting me outside to work on the car was just catastrophic emotional damage for me.
That I think, so this is another thing I think is really challenging for parents. And I've seen this time and time again. And I think it's challenging for all parents. I would say in my experience, I feel like sometimes it's particularly challenging for dads, is not just finding your kid's thing, but finding that thing that you can do together, that you can bond over, and grieving your child not being the child you thought you would have, or the relationship you thought you would have with your child. And that is not something people ever want to talk about.
Yeah.
That's not something men in particular want to talk about, but it's something that is extremely real. And especially when it's not discussed. This is part of why I love the men's support group that you guys started. Because, and again, not saying that this can't be an issue for moms and women and such, but I've seen it even more so with men. And I do think because societally, you're not supposed to talk about it. You're not supposed to, there's certain things you're not supposed to discuss or want or need, right? And that relationship with your child is one of those things. And that can be something that's really hard and really real. And people don't always know who to talk to about it, or if they even can talk about it. And it can be really tricky and really challenging to then find what is that thing where I can actually connect with my child in a really positive and wonderful way, because filling that bucket for both of you can also come back around to the original part of this topic of you're going to deal better with each other if you've been working on the relationship.
We actually had that come up. I cannot remember, but it's been fairly recent in the men's group. A guy came on and he said, "My son's really into music, and I am not a musical person, but I want to be able to know." Like, and a bunch of people were like, "Oh, go to this YouTube channel and go to this channel. Like, do you want like guitar lessons?" I know a guy. It was just a bunch of really good support.
Yeah.
And of course, there was like the people that came up and just like crack jokes, and it was a bunch of musicians who came in and started talking about. And so, but it was that camaraderie in a safe space where the joking was comfortable enough to be able to be there, but there was also really good tips and tricks and stuff like that. Men really need a lot of support, especially from their spouse when it comes to this stuff, because they may not know of their own neurodivergence. Neither parent may know of their own neurodivergence. These are things that, as you're kind of coming across, one of the number one ways we see people learn that they have ADHD, especially over 30, is one of their kids has it. They're like, "That's my story, right?" I was like, "Oh, my child has ADHD. What does this mean?" "Oh, what?"
Yeah.
Well, this is normal behavior, is it not? Nope.
People ask me if I diagnose adults, and my response is not on purpose. I have tissues on every table in every room, and it's typically for the parents, because as I describe what's going on with their child and how it's affecting them, they start crying and saying, "You just described my whole life." I'm like, "Yup."
I do this to
It's
podcast
genetic.
hosts. Yeah, I do this to podcast hosts. They have me come on because they're like, "Oh yeah, ADHD's always been really fascinating. I'd love my people to hear about it." And as we're talking about it, they're going, "So what are the symptoms?" And list out the symptoms. "Oh, okay." And I just see the gears running through their brains, and I'm like, "Yes, you are one of the 80% of podcasters that has ADHD."
So it's so funny to me because, there's sometimes, and it's oftentimes said in a negative way about like, oh, there's so many influencers and podcasters and people who have ADHD. It's like the new thing. And I'm like, no. It's because of who we are and the fact that we like to do new things and challenge ourselves, and we're creative. And it makes total sense to me that a lot of us would be ADHD. It's also fascinating to me, and this might encourage some people, as the case may be. There was a study done that showed probably about 50% of medical students are ADHD, whether they've been diagnosed or not.
Emergency room doctors and nurses, all of them.
So much of the ADHD.
So Lord, much. I had an emergency scare last year, and I wound up going into the hospital, and I'm in the ER and all my nurses are doing their thing and everybody's talking and like there's so many different conversations happening. I heard somebody's dark humor just like pop off over in the corner. And I was like, oh, that was an intrusive thought that just came out. And I said, hey, just show of hands, real random. How many of y'all have ADHD? And like everybody's hand goes up. And I'm like,
Yeah.
y'all are my people.
Yep.
Continue saving my life. So we've got to circle back. We've got a boogie monster that we've got to talk about. And this is really difficult for a lot of people in the group. They really struggle with this because they really want to figure out some natural way to treat their children and only use supplements and like all this stuff. But we got to really talk about what actually
Medication.
helps the core symptoms of ADHD.
I'm glad you brought that back around because I was going to say the other thing is medicine.
Yeah. We gotta talk about it. So talk to me about medications. What does it look like for medications and what's reasonable? What's the expectations should people have?
Absolutely. American Academy of Pediatrics recommendations, which I do humbly agree with, is that medication is first-line treatment, gold standard treatment for ADHD for everyone 6 and over. Does that mean every single person should be on ADHD medications? No. Does that mean it should be part of the conversation for every single person as soon as they're diagnosed over age 6? Yes, it does. 85% of people with ADHD will have a positive response to stimulant medications. There is no other medicine for any other condition that actually reaches those stats. Antibiotics being slight exception, but even those, right? So it's actually remarkable how well the stimulant medications work for ADHD. The other thing that I always like to make sure people are aware of is these are not new. These are not new. We've known about these molecules since the 30s and 40s, and methylphenidate and amphetamine hit the market in the 40s and the 50s. These are not new. The formulations are new. The way the medication is delivered is new, but the molecules themselves are not new. Okay, so there's that. When I talk about medicines and what they can do and what they don't do, coming back around to what we were talking about with the behavior. So first of all, let me back it up a little bit. Stimulant medications in particular, and I'll touch on non-stimulants as well, but stimulant medications in particular have the potential, at least, obviously each person's different, but they have the potential to address all the core symptoms of ADHD, meaning hyperactive and impulsivity symptoms, okay, as well as inattention and focus symptoms. So what does this mean when we're talking about the behavior stuff? Well, first of all, they actually can help with emotional dysregulation overall, just in general. But they can also help with the impulse control and the focus and attention, which means, as I like to say, pills do not build skills, but they sure as hell help us use them. Medication gives us more of a chance of actually learning the strategies and then storing the strategies in our brain in such a way that we can access them later. And then in addition to that, giving us the impulse control to actually go, instead of ready, fire, aim, or even fire, ready, aim, it gives us the ready, okay? We don't have the ready. It gives us that, oh, hold on. How do I want to do okay, wait, nope. Let me grab that strategy and use that strategy, okay? It gives us the ready, which gives us a better chance of aiming before we fire. And it even gives us a chance of deciding if we're going to fire or not, okay? And there is very little, if anything, that can do that for us like medication can. So that comes back to the behavior piece of it. We know that humans, ADHD peoples, who are treated with medication, who have optimal treatment of their ADHD, which typically includes medication, have decreased risk of depression, anxiety, substance use, substance abuse, addiction, decreased risk of accidents, suicide, self-harm, eating disorders, school failure, relationship failure, work failure. There's now research to show that people whose ADHD is optimally treated may also live longer. The statistic was that not treating our ADHD can cost 13 years off our life. Now, to be clear, that's not to say that everybody who doesn't treat their ADHD is going to die 13 years younger than they would have. It's a statistic, right? And part of what makes that number as big as it is, unfortunately, I'm not going to beat around the bush. It's the early deaths that occur because of accidents or suicide. In addition to the fact that if we manage our ADHD, we're more likely to make positive, healthy lifestyle choices and changes, such as eating better, exercising, but also, like, say we have diabetes or high blood pressure or heart disease, we're more likely to make our appointments. We're more likely to make it to our appointments. We're more likely to take our other medicines, not just our ADHD medicines. So all of that is to say that the positives that we have in the long-term research of treating ADHD far outweigh any of the risks that we've seen in the research. Now, I also always caveat everything I say with, as the research shows right now, right? Because we are always gaining more research. We're always gaining more data. Currently, in particular, we're gaining more data on girls and women. Finally, thank you, Jesus. It took them long enough, but whatever. And the other thing, too, that I always give the caveat of is we're not the easiest group to study long-term.
Yep.
Okay. We're not
Remember
consistent.
to do those surveys.
We're not consistent, right? And we're not consistent with our medicines. I mean, I find me somebody who's actually been on their medicine since they were a young child and stayed on it consistently all the way through older adulthood, and I will show you a rainbow sparkly unicorn. But the data we do have on long-term is actually pretty impressive in favor of medication, in particular stimulant medications. Now, do we have some non-stimulant medications? Yes. Have any of them been proven to be better than stimulants? Unless somebody can't tolerate stimulants, no. Have they been shown to be good in conjunction with a stimulant? Most of them, yes. But part of the challenge with the non-stimulants too, though, is it's hard to say if they're as good as a stimulant if you're not willing to do this head-to-head study, and none of them are willing to do the head-to-head study because it'll hurt their marketing.
Yeah.
Or they're scared it'll hurt their marketing. So we got to kind of take things with a grain of salt to a certain extent based on the data we have and recognizing who's provided the data that we have, right? The supplement, there are supplements that have some data behind them. None of them have enough data behind them to say this is just as good or better than medicine. All of them have been shown, if they have enough data at all, to be helpful and oftentimes even more helpful in conjunction with medication. Things like magnesium, B6, omega-3s, that kind of stuff. But none of them have been shown to be anywhere near as effective as medication. Sports, athletics, physical activity is actually the intervention that has the next best robust set of data for its positive impact on ADHD symptoms next to medicine. Still by itself, not as effective as medicine alone, but certainly not something I'm going to argue with because we could all stand to be physically active. So I'm always a big fan of encouraging physical activity. I'm a big fan of encouraging a balanced diet. No, there is not great data for elimination diets and ADHD. Can elimination of certain things for certain people help their symptoms? Sure. But for most people with ADHD, it's not going to make a huge difference. And it's one more thing that we have to deal with. It's one more thing that can be difficult.
On top of food sensitivities.
On top of sensory issues, on top of food
Yeah.
sensitivities, on top of appetite issues, on top of already a complex relationship with food. Now, to be fair, again, to note my bias where my bias exists, I also take care of patients with eating disorders. So by definition, I'm going to be a little sensitive about the food issue. Okay, so I'm going to put that out there. I have no problem acknowledging my own bias.
We see a lot of people in the group talk about, oh, I eliminated all sugars and dyes from my diet. And I'm like, first off, how did you eliminate all dyes? Because that sounds tedious as crap.
Right.
But also there needs to be a certain understanding that it's only specific dyes that cause the most issues. Like
now,
Red 40, I think there's Europeans have a really good guidelines on safe dyes to have in your.
I concur. Here's what I will say about the food dyes. Most of that stuff is in foods that aren't the greatest for you anyway. So if you want to limit those or strongly decrease them, I ain't going to argue with you. It's just you have to have a realistic expectation as to the effect that they may have. And again, are there some kids and some adults for whom it's been actually a really significant change? Yeah, sure. Absolutely. I'm not discounting that. Statistically speaking, for the majority of people, you're not going to see a substantial or truly significant benefit.
We had a conversation about this in the DMs because I was curious about if a child symptoms from ADHD go away with a healthy, balanced diet, Was
Yeah.
it ADHD or is it a nutrition issue? I love that conversation. So if
Yeah.
that's the situation,
So
what is it then?
then it's if all of the symptoms normalize with adjustments to the diet or supplementation of iron. So iron's another one that low iron can cause symptoms of ADHD. Then was it ADHD? And I think that's a question for the research. But in general, from what we know right now, the answer would be no, right? Because ADHD, like the definition of ADHD in the DSM is that another condition does not explain the symptoms. So if your symptoms go away by supplementing your iron, then you weren't ADHD, you were iron deficient anemia, and that was causing your symptoms, right? If your symptoms go away because of magnesium, we know people with ADHD need more magnesium and do better with magnesium, or at least there's some data to show that, but they're not necessarily magnesium deficient, right? So if there's a particular condition that is resolved with non-ADHD specific treatments or with nutritional supplements or what have you, then I think there's an argument there that that person maybe didn't have ADHD in the first place. They had symptoms that overlapped with ADHD that were being caused by whatever the deficiency or reaction or issue or sensitivity was.
Yeah, and I think the thing that's really important to understand here is the things that people are learning through here, and even if it is a nutritional issue, yes, you can address those issues with nutrition, but the behaviors and stuff like that, how to respond to them, all of that is super beneficial across the
Absolutely.
board because the
Absolutely.
behavior, the symptom is what we are actually working to learn to manage.
Absolutely. Linking that back into the medicines again, I cannot tell you how many kiddos over the years I've had where I meet parents and families where they're at, and sometimes they're just not ready to explore medicine, or they're willing to explore it but not start it. So we have the conversations. And there are definitely times where I'll listen to them and they're doing all the things, and the kid is still struggling, and they're struggling with that impulse control. And they know, like, the kid doesn't want to be behaving in this way. They want to be doing better. You start to see them feeling ashamed of themselves or down on themselves, or why can't I? And I'm like, okay, that's when I kind of come back around to medication, or if we're already on medication, we need to adjust the medication, right? And
That's
not saying
a
that medication fixes everything, but it does help. It can help, I should say. Can help a lot with behavior.
Let's drill into that one real quick.
Yeah.
And this will be the last thing, and then I'm going to open up the Q&A for chats. What expectations should a parent have as far as how long it's going to take to find the right medication?
Oh, that's a good one.
Because like we see it in the group, they're like, "Oh, it didn't seem like it worked or anything," or my child all of a sudden had like 1900 different side effects that all of a sudden hit,
Yeah.
or like, what's the expectations should parents?
This is something I do a lot of in my clinic, is I set expectations. So when we're talking about stimulant medications in particular, they work very quickly. We know very quickly if they're going to be effective. It can take more time to determine if side effects are going to stay around or if they're going to go. So typically what I tell people is we're going to start at the lowest dose. We're going to pick this medicine for these reasons. We're going to start at the lowest or one of the lowest doses, and we're going to titrate up, meaning adjust the dose up until we reach the most effective dose with the most tolerable or least side effects, or until we decide this medicine isn't for you, right? Either because of side effects or efficacy. And I typically titrate every week if they're tolerating it well, but there are some different ways of doing that. So you always want to listen to your physician or your provider. And sometimes we hit the nail on the head right out of the gate, right? But that's rare, okay? Sometimes we have to try multiple doses of multiple medications, and sometimes we even have to combine medications to find the right thing. And that can take months, that can take 6 months, that can take 1 month, 3 months, 6 months, a year. It can take time. And even once you find the right thing, as your body and your brain changes, your dosing or even your medication that you need can change, which can be really hard and frustrating, which is why I see my patients every 3 months, because their brains are changing at rapid paces. But when it comes to the medicine, so when it comes to side effects, so there's two things we talk about, is efficacy and side effects, right? And I tell my patients, if you start this medicine and it's like, thanks for the Tic Tac, Dr. Parcells, like you're not feeling anything, that's a good thing because it means you're not having side effects. Don't stop the medicine. It means we need to go up on it, right? The other thing I talk to them about is if we go over all the side effects and I say, look, if the side effects are mild and tolerable, try to stick with it for at least 2 weeks. After 2 weeks, what you're going to see is what you're going to get, except for appetite. That can take a little bit longer to settle out. Okay. If the side effects are not tolerable or severe, then stop the medicine. Or if we've been going up, go back down to the most tolerable dose and call me. Right. But I set expectations for all of that so that they don't just stop the medicine unless it's appropriate to do so, and so that we don't give up on the medicine. Just because these medicines are so person dependent, and the formulations, even though we're talking about same molecules, right? The formulations can vastly change how someone responds to the medication. So I'd also tell them, if we start with, so there's 2 families of medications in the stimulant medications. There's the methylphenidates and there's the amphetamines. Methylphenidates are things like Metadate CD, Ritalin, Concerta, Daytrana, Jornay, et cetera, et cetera. Focalin is over there. And then there's the amphetamines, which are things like Adderall, Vyvanse. There's now a whole bunch of new ones, Dianavel, Adzenys, et cetera, et cetera. Okay. So if you try one of the methylphenidates and you don't like it, either because it's not very effective or you have side effects, I'm typically going to still try another one in that group, because it doesn't mean you're going to react the same. Now, of course, it depends on how little efficacy and or how significant the side effects. Everybody's a little different. Sometimes we'll try 1 or 2 more in that class before we jump over. Sometimes we'll go ahead and jump over. It just depends on a bunch of factors. And same thing for the other class. And just because you have side effects or lack of efficacy in one class doesn't mean you're going to respond that way to the other class. The number of folks I've had that come to me, particularly those who have been started on Vyvanse first line, which don't get me started on that one. Vyvanse is not recommended for younger school age kids, at least not as first line. Now, that doesn't mean that I don't have younger school age kids who do very, very well on Vyvanse. But the reason for that is that there's higher risk of side effects for them. And so sometimes I'll have patients where they were started on Vyvanse, they had bad side effects, parents and or kid were like, that's it, we're not doing that, that's not for us. And so they go without treatment for months or even years before they make it to me. And then we have to kind of talk about what happened and how that's not necessarily what we're going to experience with other medications. And in fact, only 15% of people with ADHD will not be able to find a medication that works for them. The other thing I've noticed after years of doing this that I find very interesting, and it totally makes sense to me in my clinical experience, parents and kids tolerate time to efficacy more than they tolerate side effects.
Yeah.
Adults tolerate side effects more than we tolerate time to efficacy for ourselves.
That is 100% accurate.
Right? And so I use that information. That's part of why if you ask 50 different physicians how they do it, you'll get 50 different answers, because it in part depends on their own personal experience, whether or not they treat more adults versus more kids, all of that. And are there physicians out there who are really good at what they do, who use Vyvanse quicker than I do? Yeah, they've had more positive experiences with it. It is interesting because we all have kind of our own style and our own, there's the science and then there's the art, if you will.
Yeah.
But yeah, that's something I've noticed over time that's definitely affected how I choose and adjust medicines.
You're sitting here talking about the side effects and stuff like that. Like, I'm a giant baby. I'm that husband. Like, as soon as I get sick, I'm just miserable. And I would take the medication. I would have really bad side effects. Wellbutrin was like literally the worst side effect I've ever had on any medication, like including suicidal ideation.
Oh man.
And
Worse.
And it took me 2.5 years to find a good medication combination. But it took me talking to the doctor and really giving them the feedback and them going, okay, hey, yeah, on the Wellbutrin, no, never take it. We're going to put the note.
Don't do that again.
Don't ever. These are things as parents that we really need to make sure that we are doing for our children, because they can't, right? So if they're talking about their tummy is aching or their appetite is really going south and stuff like that, these are things that your doctor needs to know.
Yeah.
And your inner mama bear and papa bear is going to do the thing to get angry because your child is suffering. And like, is it really bad? Can it handle 2 weeks to see if the side effects go away? If it can't, cool, let's move into the realm of where we can. And then, look, dosage is important, right? The daily recommended dosages that are in the FDA is for a very specific, like, hierarchy or criteria for people. Some people may need more, some people may need less.
Yep.
That's a thing that we need to understand. So This has been amazing. I just wanted to say thank you, Dr. Parcells, for coming on, having this conversation with us. Where can people find you? Where do they need to look you up at? How does that work?
Yes. So thank you. I am on Instagram at the.adhd.md. I'm also sort of on TikTok, which I guess sort of still exists with that same handle. I'm on Facebook as well. My website is www.drcarolynparcells.com.
Yep.
Yep. Which also has a link to for those of you who are in Texas or in the Dallas-Fort Worth area, if there's any of those folks here, there is a link to my clinic on my website. So yeah, that's my info.
Yep. And again, you also find all that information in the doobly-doo of the YouTube channel when this comes out.
You do.
Yep. All right. So let's get into the Q&As. The first one I'm going to go ahead and ask for the chat. I've also got some others that were submitted, so we'll get into them. Our son will be 5 in March, and like you said, providers won't even see them until 6. Would love to get him a diagnosis and possible services, OT, behavioral therapy, unsure, before he starts kindergarten to give him some tools. Any ideas of what to do or where to go in the time being?
So it just kind of depends on what exactly the symptoms are. If you feel like they need that full assessment, you can certainly ask your pediatrician who in your area does those assessments for 5-year-olds. Oftentimes it's going to be something like a child study center or assessment center. If you're near an academic institution or a children's hospital, they'll often have those resources. But sometimes you don't need like the full diagnosis of ADHD or ASD or what have you to get some of those services. For example, if your concern is things like fine motor skills or sensory issues or things like that, that an OT or an OT-PT would be helpful for, you can ask your pediatrician for referral to PT/OT, and then they can kind of do their own assessments and do some of those services even without like a full diagnosis of ADHD or ASD. So that's one option. Certainly, too, if depending on what the child is struggling with, especially if they're starting to show signs of some anxiety or things like that, play therapy. Like I said, those therapies aren't going to necessarily help with ADHD symptoms, but if we're trying to just develop positive coping strategies for dealing with life and dealing with anxiety and dealing with being more flexible and those kinds of things, then sometimes a good play therapist can really be helpful for that as well. And typically, your pediatrician should have references or referrals for those kinds of things.
That's awesome. All right, I've got a long one for you on this one. So this person, they missed the beginning of the Zoom, so you may have talked about some of this stuff, but the boy is on Focalin, 10 milligrams. He says it does help him with focus, but he's still seeing behavioral reports from school showing that he's disruptive in class. He makes noises and cannot sit still. They tried to bump the Focalin up to 15 milligram, but he would not sleep at night, so we went back down to 10. Is there something different that can help him with his school behavior?
Sure. So I'm going to give my little caveat here
Mm.
of nothing I say here is intended to be direct medical advice. Always talk to your own provider. This is for educational purposes only. There you go. Okay. So in general, that's how I'm going to talk about it. In general, if a medication, so this is a pretty classic situation, right? Where we're having trouble finding an optimal dose of a particular medication because the dose that's tolerated before side effects isn't getting us either full efficacy during the day, or it's not getting us the duration or the length during the day that we need, right? So there's a couple of different ways to go about that. One is to just change the medication altogether, is to try a different formulation, see if it's better tolerated, if you get more efficacy, if you get longer action out of it. The other option is when you find a formulation that if you feel like a formulation and a dose really works for a kid, it's just not getting them all the way through their day, then that's another time where certainly you can try another formulation, or you can try adding a booster dose of a short acting in the afternoon so that it doesn't kind of get them all the way into like difficulty getting to bed at night. In a situation in general, for me, if I'm taking care of a kiddo where we're not having optimal efficacy at all, so like if it's like on a particular dose, it's not optimal at any point throughout the day, and it's not getting us through the day, but if we go up, we can't tolerate it, to me, that's a sign that it's probably time to try a different formulation. Now, sometimes if I have a child or a patient who has tried multiple formulations and they're sensitive, we're struggling to get optimal effect, without side effects, then that's also a time where I might consider adding an adjunct, like one of the non-stimulants, like Intuniv, which is guanfacine ER or something like that. But in general, for me, if I have a kiddo for whom we can't get to they can't tolerate a dose that gives us optimal effect, then it's time to try something else. But it just really depends on the kid.
Well, also, we have to look at the other side of this coin. Has a child learned how to behave?
Sure. No,
Like,
absolutely. Well,
now that now
thank
that
you.
things are starting to work,
Sure.
have they
Have
relearned
we
how to
given them
behave?
time? And the other part of that too, Shane, thank you so much for bringing that up. The other side of this coin is how much of it is the kid and how much of it's their environment, right? So, like, for example, if
How
you have a kid,
boring is the teacher? I'm
well,
sorry.
right. Or how
Sorry.
sensitive is the teacher to the behaviors? And again, this is no shade to teachers, but some teachers are just manage these kids better than others. So like if he say this kiddo has great scores and we're not getting complaints from 3 out of the 4 teachers, but one of the teachers is saying they just can't sit still. Well, what time of day does that teacher
Yeah.
see the child? What is the subject? What is the teacher's approach to the child? And what are the parents seeing like on the weekends when the child is on the medicine? That kind of thing. So you're right, Shane. Thank you for bringing that up. There's a lot of other factors that can come into play before we just say it's absolutely the medicine. But if we think it's the medicine, then those are the ways I usually manage it.
Yeah, it's one of those things that we have to kind of, you talked about time of day, and we also have to kind of like, look, just because the child's on medication doesn't mean income, interest, novelty, challenging, urgency, passion is not still the way that we work. That still is how our
Great
brain
statement.
works. And if the class is super boring, if the teacher's super boring, if it happens to be next to the pretty girl or pretty boy next to us, if it happens to be on a day where it's sunshiny outside and it's 2 o'clock and that child is just like, check the hell out. But medication is only part of the solution, y'all.
Exactly.
um,
Exactly.
Also, I want to switch to a thing that's relevant to this. That's a question from earlier. What about the person was talking about their child seems to come home and completely melt down as soon as they get into the house and like somebody starts to ask them to do a chore or just like they're constantly complaining about being tired and hungry and just kind of very completely like broken down after
Yeah.
school. But like
Yeah.
at school, they were great, but then they got home.
Common. And in fact, this is one of the reasons why I get really irritated sometimes because, so yes, when we're talking about diagnosing ADHD, we have to show that the symptoms exist in multiple environments because we want to make sure that it's not just an environmental issue, not a kid issue, right? Or not an ADHD issue. But, and this has been the source of shame for parents for decades, but they do fine at school, so it must be parenting. No, they're using literally all of their mental and emotional and physical energy to hold their shit together all day during school because it's not a safe space to let go because there's social pressure. Oh, by the way, structure does help them keep it together. But when you have a kid who's literally using every ounce, I mean, we do this. If we have a hard day at work, or every day is a hard day at work, right? And we have used everything we've got because if we let it go at work, we're going to lose our job or get sent to HR. And then we get home, which is our safe space because these people aren't going anywhere, right? Who do we take it out on? Who do we let loose on? So why do we expect our kids to do better than we do? Okay. So yeah, first of all, if this is a child who, let's take medicine out of the mix, right? Just the fact that they could be using literally everything, every ounce of everything they've got just to get through the day. And then when they get home, they're in their safe space. They know you're not going anywhere, right? This is where they can just let it go. And when you ask them to do one more thing when they have 0 left in the bucket, it's not going to go well, right? So there's that. Oh, by the way, is the child eating? This is whether they're on meds or not. Did they eat breakfast? Did they eat lunch? What time is their lunch? Because some of these schools are feeding kids lunch at like 10:30, 11 o'clock in the morning, and then they don't get out until 4. Is this kid hangry? Do we need to have snacks in the car and just shove food in their face the minute you see them before you ask anything of them? Okay. Are we getting enough sleep? Are we having disrupted sleep or difficulty getting to sleep? Because God knows that's a thing for us too. And so then again, we're just crashing by the end of the school day. Now, complicate things even further. Oh, by the way, are we being bullied? Do we have friends? Are we having social issues? All of those things can contribute. Now, as if that's not all enough, let's say we are taking medicine, okay? Perhaps our medicine isn't optimized and we are still having to use all of that energy and what have you, so we're melting down when we get home. That's a possibility. The other possibility is for the long-acting medications, for some people, not all people, they will have a side effect of increased emotionality is the word we like to use, or emotionally labile, in the 1 to 2 hours when they're coming off the medicine. For some people, this comes across as being tearful. For some, it's meltdowns. For some, it's angry. For some, it's just isolated and removed. So is that contributing, right, to the behavior if it's a kid who's on a medication? So all of these things can contribute. But one of the things I always tell parents, and yes, structure and consistency is helpful, that your child losing their crap at home is a compliment because they feel safe to do so with you.
So
I think that's a major reframe that we all need to hear more and get behind more.
yeah, like that's what those are some of the things that I do when the kids get home. Is just like, all right, go grab you a snack. And they have this drawer that is just packed with Costco goodies and things like that. But it's all relatively healthy, except for the Welch's gummies. But
food, and it gives them the illusion of choice.
and it's just, but it's all, they have it. It's easy to access. We made it every they're 5, so we make it where they don't even have to talk to us when they get home. They just like go do their things and like let them have their time. And then like they get home at 3:30, 3:45, 4 o'clock. Then 5 o'clock after 1 hour, we're like, hey, let's talk about doing homework. The alarm's gone off. We've agreed that 5 o'clock is homework time because we did the condition. Let's talk about time after you get home. How much time do you need to rest? Right.
And
it's really important to have that.
It is really important. And that's one of those times where the collaborative problem solving can come into play, because for other kids, right, stopping their momentum might not work for them. It might make homework time harder if you wait to do it. Or if they are on meds, their meds might have worn off by then. So that's one of those where that's awesome because that works for your kids and that works for your family.
Yeah.
For other folks, that might not work as well. And so that's, again, where that kind of collaborative problem solving kind of can come into play, especially if you've set something either like that plan or like you do homework as soon as you get home and it's not working, right?
Yeah.
And it's a constant battle. Then sit down and go, okay, this isn't working. So let's talk about other alternatives as to what might work. The non-negotiable is your homework has to get done.
Right.
It has to get done on time. So how do we manage that? Right. Because and I feel like, and it's funny because I was one that I had to, it was so hard for me to do stuff when I first got home. On the other hand, if I stopped my momentum, I was screwed. And so I was always having to kind of go back and forth, which, by the way, this is also why for a lot of us, we do better the busier we are until we hit the point of too busy and then it all falls apart.
Yep.
But that's why competitive swimming is probably why I survived high school.
I mean,
But
football was mine.
okay. There you go.
Football was mine. Like that was my social circle and everything. And also I got all my aggression out.
It made my brain work better and it made me so structured that I only had certain amounts of time to do stuff.
Yeah, we're talking about gymnastics for our kiddos because they've been watching Simone Biles videos because that's been having a fixation. And they're just like, oh, I want to do it like her. I can do that. And I'm like,
that's cool.
She makes it look
easy,
really hard.
But gymnastics is great for ADHD.
My child is 8 years old and has been on Adderall for a couple of years now, intertwined with guanfacine for his side effects. But now he's experiencing a lot of aggressive tendencies with his younger siblings. Would that be a medication side effect or just sibling rivalries?
How old was he again?
8 years old.
Oh, right. So what I'm going to say is, again, it's, so hard to give much in the way of a specific advice for a specific situation. But here's what I will say. Puberty, now that's a little young for puberty in males, but puberty does absolutely change how we respond, how it changes our ADHD. Our ADHD usually gets a little worse. but also it can change how we respond to medication. So I absolutely have had kids, boys in particular, that were doing really well on a particular medicine. They hit puberty and they become more irritable and aggressive in general. And I do see that more with the amphetamine class, which is like Adderall and Vyvanse and those, than I do with the methylphenidates. We also know that the younger the kid, the more likely they are to have side effects with the amphetamine class of medications. So again, Adderall and Vyvanse and those, which is why we tend to start with methylphenidates first in that age group. But again, doesn't mean I don't have kids on amphetamines who are that young and younger who do very well on them. It just depends, right? The challenge is it's really hard to say whether or not that's a potential side effect of medication versus medication's not working well enough, so we're not having the impulse control, versus sibling rivalry stuff without knowing more details about the kid, all the kids involved, the family dynamic, how long we've been on the medicine.
Right.
So that's definitely something that I would absolutely speak with your prescriber about, okay? And talk about what the options are for trying to figure out whether or not it's medication side effect versus sibling rivalry versus none of the above, but still something that needs to be addressed. It reminds me of something, I say this to folks all the time. Something can be developmentally appropriate and normal and still be something that we as parents need to address, right? Okay. Tantrums are completely normal in toddlers. It's still our job as parents to try to teach them how to emotionally regulate when we can, right? Being curious and testing boundaries and all of that is totally normal, totally developmentally normal for kids. It's also our job as parents to set those boundaries and teach them those boundaries. So it's very possible, with more details, that the behavior is normal or developmentally appropriate, but that doesn't mean we don't need to address it. And the question is, how do we address it? And that also comes back around to what's actually causing it. What's the underlying issue? Also, being an oldest sibling, what are their younger siblings or other siblings doing to poke the bear to make him react so he gets in trouble? Thank you very much.
As an only child with cousins.
It just depends. But I do think it's something that they should discuss with their provider.
But also, this also is a good thing to look at. We kind of touch on environment a lot, but we also need to realize that children are only home or at school 8 hours a day. What are they learning at school? 8 years old? That's the criteria. Yeah, that's a place where, educationally speaking, they're around children who are old enough who may be bullying them. They've
Yep.
also started learning more different types of social interaction
Great.
we had on.
Yep.
And they may be getting this, they may be experiencing this as part of their very close-knit friend group, as that's
Yeah.
kind of how they're doing, especially boys with
Yes.
really hyperactive friends and stuff like that. And they're just doing the same thing at home with their siblings, and that's not okay because their siblings are
Right.
not they're not ready for that kind of roughhousing, or they're not ready for that kind of aggressive behavior. I'm imagining, like, back in the day whenever I learned slaps, that was I was definitely 8 years old when I learned slaps, and like going home, and I can imagine doing that to like my 4-year-old sibling here with no reflexes at all. Gotcha. Right. So let's make sure we're like what Dr. Parcells said.
That's
Let's make sure
fabulous point.
we are paying attention to the environment and what they're learning and where they're learning it, and
Where they're learning it from.
how do we differentiate? All right, this kind of stuff is things that you're learning from your friends. Let's keep that with your friends. Don't do this with your siblings.
Right.
Now,
Right.
impulsivity is still going to be an issue. They're still going to do those things. But again, to Carolyn's point, we don't know, so we can only answer so much there. So, but it's been a fun thought experiment for us. So sorry that you're going through that, but at the same time, hopefully this can help you with those different things.
Being the mother of 2 boys, I feel you, sister or brother. I don't know who asked that question.
So we've talked about sleep. The question that I've got here now is, I've been trying to get my child to go to sleep at a reasonable time, 8 a.m. or 8 p.m.
Fun.
But they keep waking up too early. And what do I do? I have a second question on this one.
Oh, go ahead.
Are they waking up, like, literally 8 hours later, which would be a normal amount of sleep for them.
Yes.
Like, so
I was going to
but
ask the same thing.
Yeah.
ADHD folks, we tend to have more of a difficulty getting to sleep. That doesn't mean some of us don't have difficulty staying asleep. I agree with you. The real question is when we say waking up too early, are we talking about going to bed at 8 and waking up at midnight or 1 or 2 and falling right back asleep? Or waking up at midnight, 1 or 2, and we can't get back to sleep? Or waking up at 4 and we can't get back to sleep? So 10 hours of sleep is what we recommend. You want to allow for the possibility of 10 hours of sleep for pretty much all school-age children until adolescence. It's 9 to 10 hours. The average is 9.25. Recognizing that not all humans have the same circadian rhythm and not all humans have the same sleep need. There are humans who need 10 hours. There are humans who need 12 hours. There are humans who need 6 hours, 7 hours, 8 hours. So it is possible that you have a child that does not, if you're allowing for 10 hours of sleep and they're getting consistently 8 or 9 hours of sleep, but they are appearing well rested, they're not falling asleep in class or during the day, their behavior doesn't seem to be adversely affected by it, as best you can tell, then that may just be that child's sleep pattern. If it's like, no, it's genuinely not enough, we know it's not enough either because the number of hours or because of behavior or what have you, then that is when it's early awakening instead of difficulty getting to sleep. Things that I would look for: do we snore? Do we have restless legs? Do we move around in our sleep a lot? Low iron levels can actually contribute to that, but that's not something you want to supplement without checking a blood level with your provider because you can get too much iron. Is this someone who maybe needs a sleep assessment, either to see if they've got obstructive sleep apnea, central sleep apnea? There's a slew of other sleep disturbances, and certainly sleep disturbance can contribute to behavioral challenges. Our ADHD and our behaviors are worse. And even if we don't have ADHD, everything's worse if we don't have enough sleep. There's a reason it's used as a form of torture. So again, it just depends. And it may be that this child just has less of a sleep need, in which case it might make sense to shift their sleep schedule. But there's a lot of factors that come into that. And again, talk to your pediatrician.
Yeah, that's going to be the number one thing. But like you were talking about sleep assessments and everything, that's how I found out I have a later sleep circadian rhythm. And I was like, what does that mean?
They chronophenotype.
Yeah, like, and it's very specific to people with ADHD, where 2 hours later is our normal.
On average, an hour and a half later than same age, same gender peers.
Yeah. And I'm like, I knew it. Like all my life, I knew this. And I cannot tell you, like, my doctor was so confused when I was just giggling about that shit. I knew I needed more sleep, but it had to be a specific time. And I was like, by the way, for all of y'all out there, and this is me putting on a business hat, if you happen to have a natural later sleeping circadian rhythm and you can get up at 8 o'clock in the morning, maybe go to sleep later and see if that helps. That's something to think about. Work with your doctor on that. This is not medical advice. One more final question, and then we're going to call it wraps, and you've been amazing. My 9-year-old son wakes up every 2 hours at night whining or crying. Could this be part of ADHD? He's on guanfacine in the morning and clonidine at night. Ooh.
That's a tough one. So again, we do tend to have difficulty with sleep cycle. Waking up every 2 hours, though, whining or crying or those kinds of things, the first thing I always start with is talking to them. And sometimes it's not talking to them in the middle of the night because nobody has the energy for that. But I'll ask them, can you tell what's waking you up? And sometimes it's the room is too hot. Sometimes the room is too cold. Sometimes they kick their blanket off of them. Sometimes it's the family pet that has woken them up. Sometimes it's a noise outside the window or the door or what have you. So it can be one of those things. Sometimes it's nightmares. But again,
our clothing sensitivities.
Yep, clothing sensitivities, or again, getting too hot because maybe we're wearing more than we need, and our body temperature does go up at night, and some people just don't tolerate that as much. But even things like other things that can cause us to wake up: tummy aches. Are they having headaches? that needs to be evaluated. If they're being woken up at night by headaches, that needs to be evaluated immediately. But also, again, allergies, asthma, obstructive sleep apnea, snoring. Is there something else going? So snoring, which can be a sign of obstructive sleep apnea in children, if that's going on, what happens is eventually they kind of stop breathing for a minute until their brain wakes them up to make them breathe. And for some people, that just kind of barely wakes them up and they go right back to sleep, and it disrupts their sleep, but not so much that they wake up. For other people, it wakes them up, right? And sometimes that can be something as simple as seasonal allergies, right?
Mhm.
And for other people, it can be tonsils and adenoids that actually need to be dealt with or removed. So there can be a whole, especially if they're waking up consistently through the night. And because clonidine helps with sleep initiation, but it can actually help somewhat with sleep maintenance too, which means staying asleep. So if they're continuing to wake up throughout the night, especially despite being on clonidine, absolutely need to see the pediatrician and may need to have an assessment by an ear, nose, and throat doctor and or sleep medicine to see what's going on there. But absolutely start with the pediatrician.
I
I
know.
wouldn't chalk that up to just ADHD. I would
Yeah.
want a full assessment.
Yeah, that's definitely in. I had night terrors for a long time on one medication. I can't remember what it, actually, I think it was guanfacine.
So guanfacine
Um,
and clonidine, they primarily help with sleep, irritability, emotional dysregulation, rejection sensitivity, dysphoria, hyperactivity, impulsivity, anxiety. They're not as good for focus and attention, but 3 to 5% of people will have the opposite reaction, where it actually makes them more irritable. And while a lot of people will have the same reaction to both clonidine and guanfacine, some people will have a different reaction. So some people will have that response to either clonidine and guanfacine and not have that response to the other one. So that could also be something to consider. That you'd have to look at the timeline. But again, if we're waking that much, that's definitely needs assessment beyond just chalking it up to ADHD.
yeah. And we got to realize we're working with brain here, y'all. Like it doesn't take much for our brains to start having really crazy things
We're
happen.
so
And
sensitive.
yeah, so when we're introducing medication and then we start talking about puberty or we start talking about different experiences in the environment, this is super
All the things.
complicated. But I want to say thank you to everybody who came, for everybody who's watching. I really appreciate all of you. I do want to wrap this up and everything. And again, I just really want to say thank you so much for coming on. And again, all the information for Dr. Carolyn will be in the doobly-doo below. Everyone, y'all have a great day.
Thanks.